Module B, Interview and Health History. This is a list of your objectives. You should be able to successfully answer these objectives once this module is complete. So the interview is the very first point of contact that we have with the client. This is where we are going to start to obtaining their health history. With this health history, it's going to give us a better understanding of the client's beliefs, their concerns, what brings them into the clinic today, and a perception of their individual's health status. How do they feel about their health? There is two types of data that we are going to collect. The first one is subjective data. This is what the person says. Subjective data is what they say to us. The second type of data is the objective data. The objective data, this is what we are going to collect. Objective data is going to be like the vital signs, the blood pressure, the temperature, the heart rate. There is a couple of types of communication. We have verbal communication and then we have non-verbal communication. Verbal communication is pretty self-explanatory. This is words that are spoken. It's vocalization. But we need to be mindful of the type of verbal communication that we're receiving from the client. We want to be mindful of the tone that this client is using when they are describing their signs and symptoms, or even just in general conversation. So be mindful of the tone. And we also need to be mindful of our tone that we use when we are speaking with a client. Nonverbal communication, this is body language. This is facial expressions. What is the client doing with their hands or arms? Body language is actually sometimes more important than the verbal communication, because they can be telling us one thing, but be mindful of that body language, okay? Because that body language, that is going to correlate with their true feelings. That's going to give us a more accurate understanding of what's going on with this client. As nurses, we need to make sure that we are receiving the verbal and nonverbal communication accurately. We need to make sure that we are aware and we understand the message that is being given. Gestures, that nonverbal communication. Gestures are as important as words. Interpretations based on past experiences, cultures, and self-concepts. If we don't have a clear understanding of what the client is trying to tell us, so if we misunderstand something in the healthcare setting, this can tremendously impact the well-being of the client. The health history is obtained through the interview process. This is where we are going to collect and record the data that the client is telling us and the objective data that we obtain. The nurse is going to learn about the client's health concerns. We're going to become more familiar about their social environment, their economic and cultural factors that influence their health. And we're also going to try to get a better understanding of how they feel and how they react to their disease process or the illness that they have. And remember, we're going to be collecting a lot of subjective data. This is what the client is saying about themselves. We need to be mindful of several things when we are in the interview process of a client. We want to make sure that we provide privacy for this client. A lot of times a private room is not available. If that is the case, then we need to make sure that we pull the curtain to ensure as much privacy as possible. If a client, if they're out in the open where people is walking around and there's a lot of traffic, they're not going to be as open to you. They're not going to feel as comfortable with the communication. We want to make sure that we, as the interviewer, we refuse interruptions. We want to make sure that we give this client our uninterrupted attention. This is going to give the nurse time to concentrate on what the client is saying, and it also is going to be able to give the nurse and the client a chance to establish a good working rapport with one another. We want to make sure that our appearance is professional and somewhat, comfortable. An individual is less likely to feel comfortable if they come in and you're doing an interview and you're in a three-piece suit, okay? So, scrubs, business casual clothes, but you want to have a clean, professional appearance. Note taking. You want to keep this to as much of a minimum as possible because you want to be able to focus on what they're saying and you want to have eye contact with them. You want to offer your focused attention. If you're just writing non-stop and looking down at your paper or iPad, they're going to think that you're not paying attention or that you don't care enough to really listen to them. So this is where, we've got to learn to make those mental notes, jot down things here and there, but pretty much you want to offer that uninterrupted attention. The physical environment, the room and the area that you're doing the interview in, you want to make sure that it is comfortable. You want to make sure that the room temperature is at a comfortable level. If it's sub-zero and the client's freezing to death, all they're going to be thinking about is getting out of there, okay? So you want to make sure the temperature is at a comfortable level. Lighting, you want to make sure that there is sufficient lighting for you to do your assessment and take your notes. Noise reduction. You don't want to have a lot of noises. You don't want to have any distractions or interruptions. When you have interruptions, this does a couple of things. This tends to make the client feel like they're not important, that you're not listening to them. You have other stuff going on. And it also, you lose your train of thought and the client will lose his or her train of thought. You want to make sure you maintain a good and comfortable distance between you and the client. Typically 4 to 5 feet is a good distance, or twice an arm's length is a good distance to maintain between you and the client. And you want to make sure you're at equal seating heights. If you as the nurse, if you're sitting up above the client and it's like you're looking down on them, they feel like you are superior, that you are more important than them. So make sure you're sitting at eye level with the client or below the client. You want to make sure you're not sitting behind a desk or a podium or some sort of table, okay? You want to have that open air between you and the client. And you don't want to stand. Don't stand over your client. This is going to make them feel like, you're in a hurry to try to get out of the room. That you don't have the time to sit down and listen to their thought process. Now we're going to start breaking down the actual interview itself. The interview itself has 3 phases. We have the introduction phase, the working phase, and then the closing phase. And we're going to break these down and go in depth into each phase. Each phase is very important, so please pay special attention and know the different areas and the different types of content that is covered during each phase. The first phase is the introduction phase. This is where you are going to meet your client. This is where you are going to address your client. And we like to address them by using his or her surname. Surname is their last name. So you're going to introduce yourself, Mr. Jones, Miss Jones. My name is Jennifer, and I am going to be your nurse today. So you want to address your client, call them by their name, again, their surname. You do not want to use their first name unless they give you permission. By all means, if you address them as Mr. Jones and he says, please call me, my name is Doug, then yes, absolutely, you call them by their first name. Excuse me. After we address them, we're going to introduce ourselves and we're going to state our role. What are we doing there today? So, Mr. Jones, my name is Jennifer and I am going to be your nurse today. The next part of the introduction phase is the reason for the interview. Why are you there? You want to give them a brief explanation of what you're doing, and let them know about how long it's going to take to complete this interview. So, introduction phase. Hello, Mr. Jones. My name is Jennifer. I'm going to be your nurse today. I am going to be completing an interview. I'm going to be collecting your health history from you, and this is going to take about 10 minutes to complete. That is the introduction phase. The next phase is the working phase. The working phase is where you're going to start gathering that information. You're going to ask the client questions, and you're going to be recording their responses. And remember, the responses, we have verbal responses and we have non-verbal. Verbal communication, non-verbal communication. So during this working phase, there are 2 main types of questions that we are going to ask. We're going to ask open-ended questions, and then we're going to ask closed or direct questions. Open-ended questions, they're going to ask narrative information. They're going to ask for that narrative information. So you are going to ask a question and you are going to want your client to kind of tell you a story to answer your question. These are particularly used at the beginning of the interview, or when we are changing the subject, or moving on to another series of questions. We're going to use those open-ended questions. Some examples of open-ended questions are, tell me why you have come here today. What brings you to the hospital? Those are 2 examples of open-ended questions. So we want them to kind of elaborate on their answer. A closed or a direct question, we are asking for specific information. Most of the time, these are going to be 1 or 2 word answers, or they can answer them with yes and no. We're going to use this type of questioning when we are wanting specific facts. We are wanting something specific. We're not wanting any other fluff or any other details. So we want very specific information. So now that we've talked about the 2 types of questions that we're going to ask, we need to know about the types of responses that we are going to receive from the client, and terminology and things that we as the nurse is going to use to keep the conversation going. We also want to make sure that we keep the client focused on the question at hand, the question that we ask. We want to make sure that we keep them on that mind track. So the first one that we're going to talk about is facilitation. Facilitation is where we are going to encourage that client to say more. We can encourage them to continue their narrative without necessarily interrupting their train of thought. So things that we can say is, continue, go on, or simply nodding your head. Remember that non-verbal communication. All the while, you're making eye contact with this client. So you're just encouraging this conversation to continue. You want them to elaborate a little more. Silence. Silence is important for communication, that the client has time to think and organize his or her thoughts without you interrupting them. I know a lot of people are uncomfortable with silence, but silence is a good thing. It allows you as the nurse to observe the client. You want to look at those nonverbal clues. It's going to give you a chance to organize your thoughts. Think of maybe the next question that you need to ask, maybe a follow-up question. And it's also going to give the client time to think and make sure that they have completed their thoughts and their sentence. Reflection. Reflection is an echo. It's an echo of the patient's or the client's own words. This involves repeating part of what the client has just stated to you. It focuses further attention on a specific phrase, and it will also help the client complete his or her thought process. Here's an example. So after the meeting with the physician, you are very frustrated because you feel he did not listen to your concerns. So what you're doing is you are echoing back what the client said to you, okay? But you're doing it in a question form, so you're making sure that you understand what they're telling you. The next response is empathy. This is where you recognize a feeling and you put it into words. Do not confuse this with sympathy. Sympathy and empathy are two separate things, okay? Empathy is where you are again, recognizing that feeling. This must be very hard for you. Or simply placing your hand on your client's arm or shoulder, or holding your client's hand during a difficult situation. This is a form of empathy. When we as nurses, when we use empathy, this helps the client feel more accepted. It makes them feel like you understand, and that they can deal with the feelings openly. They don't feel like they have to hide or shut down their feelings. Clarification. This is used when the patient's words that they are speaking are a little confusing, or you don't completely understand. So you can follow up with, pardon me, would you mind repeating that? Or something, I'm not sure I'm following you. Can you explain it to me in a different way? Or can you go into a little more depth with that? This is very important because we've got to make sure that we understand what our client is trying to tell us. Next, we have interpretation. Interpretation is what we as the nurse base our conclusion from the data that we obtained. Okay, so an interpretive response is different than confrontation, okay, because interpretation is what we gathered from hearing the client talk or what they are saying to us. So you have somebody come into the clinic, with, abdominal pains from time to time. And you've noticed that every time they come in with these abdominal pains, they've had some sort of stressful event happen in their life. So your interpretation could be worded like, it seems that every time you feel the stomach pain, you have had some kind of stress in your life. So that is our interpretation of the stomach pain that the client is having. But we do want to make sure that we are very careful not to allow our emotions or beliefs affect our interpretation. The beginning of the slide, I mentioned, we have to separate our cultures and our beliefs. We have to keep them completely separate from our clients. The next one is explanation. This is where we are going to give facts. We are going to give objective information to the client. It could be something as simple as orientating your client to the hospital. Say they are a brand new admit, and you are simply telling them, okay, breakfast comes at 8 o'clock, lunch comes between 11:30 and 12, and dinner comes between 5 and 6 o'clock. Those are facts that you are giving to the client. Another fact is if a client is NPO, meaning they cannot have anything to eat or drink, okay, they're going to know why. Well, the reason you cannot eat or drink before your blood test is that the food or water can alter your test results. Again, facts. And the last part of the working phase is the summary. This is the final review of what you have gathered from the client and from what the client has reported to you. It condenses all the facts, and it presents a survey of how you perceive the client's health problem or their need, that the reason they came into the clinic or the hospital. During this time, it will also allow the client to correct any misperceptions or any misunderstandings. The very last part of the interview process is closing out the interview. You want to make sure that this meeting ends gracefully, very politely. You want to ease into the closing by asking, is there anything else you would like to mention? Are there any other problems or concerns that you may have? This gives them a final opportunity to express themselves. This is also a final statement of what you and the patient agree on. Gives you just that one last time to make sure you understand everything clearly. Next part of the interview process are some traps. Okay, it's called 10 traps of interviewing the client. This is like non-productive, defeating verbal messages that's going to restrict that client's response. They're obstacles to obtaining complete data and establishing a good rapport with your client. So we're going to break these down and go into each one of them. The first one is providing false reassurance. An example of this is, now don't worry, I'm sure you'll be all right. We don't want to provide that false reassurance. Yes, sometimes that's the easiest thing for us to say. Sometimes it makes us feel better as a nurse or a caregiver, because we feel like we're taking that worry away from that client. But a lot of times that's not the truth, okay? And we don't want to lie or provide that false reassurance. It can close off communication with the client. It kind of cause them to shut down. It can sometimes even make the client feel like you're not really listening to them, that the anxiety that they may be having over the situation is just kind of brushed under the rug. Oh, it's okay, don't worry about it. You're just saying that to just kind of hush them up, or make them be quiet about the situation. Number 2 is giving unwanted advice. This can shift the accountability for decision making from the patient to you. So the doctor come in and talked to the client and told them that they needed this, major surgery, and they have a decision they need to make, and they're talking to you about it. And at the end of that, sentence, after they were telling you about the surgery, the last thing they say is, well, what would you do? And after that question, our first, response, it's going to be, well, if I were you, I would. Okay, we don't need to do that. Okay, the client has to make the decision for him or herself. Number 3 is using authority. This can promote inferiority and dependency. It doesn't allow the client to really think for themselves. Some terminology can be like, if you said your provider knows best, your doctor knows best. This can make the client feel belittled, or that, you know, how they think or feel about their health is not important. Just because somebody is a doctor or nurse, that, you know, they automatically know better. And this is not the case. So we have to be careful about our words that we use. Number 4 is using avoidance language. This is when we use words or terms to avoid reality or to hide true feelings. When you could use the term, you know, like passed on instead of, you know, deceased or died. Number 5 is engaging in distancing. Distancing is the use of impersonal speech to put a space between a threat and oneself. An example of this can be the sentence, there is a lump in the left breast. Whereas, you know, the proper way would be is there is a lump in your left breast. When you use the word your, that is personal, that is making the client kind of own that diagnosis. Number 6 is using professional jargon. We need to make sure that we are using proper terms that the client understands. You are fixing to learn a lot of medical terminology. Okay, a lot of it you've never heard before, especially if you've never worked in the medical field. So remember this, how you feel right now when you are starting to treat clients. So if you're using medical jargon, you know, hypertension, hypotension, hyperthyroidism. Okay, they don't understand that. So we need to make sure we use words that they understand. High blood pressure, low blood pressure. Leading or biased questions. This is number 7. So when we ask questions, we don't want to ask a question with it leading to an answer. So an example of this, you don't smoke, do you? Okay, well, you should ask it as, do you smoke? That is a yes or no question. But when you word it as, you don't smoke, do you? Well, they're going to be like, well, no, because even if they did, it's going to kind of put them on the defensive, okay? It's almost like they're going to feel like you're judging them. Number 8 is talking too much. You should always make sure you are listening to your client. You want to listen more than you are talking to them. If you're doing all the talking, then you're not adequately getting your history that you need from the client. And if you're talking all the time, they're going to shut down because they're going to think, they just want to do all the talking, so I don't have a chance to get a word in edgewise. So you want to make sure you are listening more than you are talking. Interrupting. You don't want to cut your client off mid-sentence, all right? You want to make sure you let them complete their sentence, complete their thought process. Number 10 is asking why questions. When we follow a question up with why, this makes it sound like we're blaming them or we're condemning them because they are doing something. When we ask them, do you smoke? Why? Okay, that's not our place to ask why. Yes, there's follow-up questions that we want to ask, but we don't ask why. Again, that will make the client feel like you're blaming them for something or you're judging them. They're going to become very defensive in their answers and they're going to shut down. Nonverbal skills. So nonverbal messages that are productive and enhancing to the relationship are those that show attentiveness. They show that attention and that acceptance that you have to them. And when we are interviewing the client, we need to make sure that we are paying attention to the verbal and nonverbal messages. We want to make sure that they match. So when a verbal and nonverbal message are congruent or they match, then the verbal message is reinforced, okay? The verbal message is reinforced by that nonverbal action. When these two are incongruent, meaning they don't match, then the nonverbal message is viewed as the true message, okay? So if you have someone sitting there, they tell you that they don't have anxiety or that they're not nervous, but they are fidgeting and they're moving and they're shaking their legs and they just are just so antsy and everything, then that nonverbal message, that is the true message, okay? That is the true message that, yes, they are nervous, they are having some anxiety. So that nonverbal cue, nonverbal message, it trumps the verbal message. So some modes of nonverbal communication from the interviewer side is our appearance, okay? We want to make sure that our appearance is appropriate, is professional. Our posture is appropriate, relaxed, comfortable. That we want to make sure that we're sending off the right gestures, sending out the right nonverbal messages, that we are there to listen to their concerns. Our facial expressions, we want to make sure that our faces are relaxed, that our facial expressions reflect a positive sense of emotion and attitude. We want to maintain eye contact at all times, but we do need to be mindful that there are some cultures that prohibit eye contact, and so we do need to be aware of that if there is some cultural diversity, that we do not maintain the eye contact. Our voice, we need to be aware of our tone, the intensity, the pitch, the rate of speech. We want to make sure we speak in a clear, slow, concise voice. And even touch. It depends on age, gender, and the situation. Remember, empathy plays a big part into the physical touch of clients. So we've talked about getting ready to do the health assessment, the things that we need to make sure that we do or don't do during the interview process. Now we're going to start talking about the health history itself, the purpose of the health history, why we want to do this, why it's so important. So the purpose of the health history is this is where we're going to collect that subjective data, and we're going to combine it with the objective data that we will obtain from the physical exam and the blood work that we obtain from the client. This is going to help provide a complete picture of the client's past and present health status. We can use this as a screening tool to help detect disease processes that may not have been diagnosed yet. Any type of abnormalities that are starting to show up, maybe in blood work or vital signs. So some things that we're going to collect during this health history is the biographic data. Name, address, phone number, age, birth date, birthplace, sex, relationship status, race, ethnicity. The occupation is important for us to know, language. We also want to know who is giving the information. Is it the client themselves or is it a surrogate? A surrogate can be a caregiver, it could be a spouse, it could be a parent. And the reason that they are seeking care today, this is called the chief complaint. The chief complaint is a statement in the client's own words that describe the reason for the visit. So the chief complaint is always going to be subjective data. This is what the client says is wrong with them. The present health or the history of the present illness. This is a chronologic record of why they are seeking care. We want to know the time that the symptoms started up until the time that they are seeking care. There is a mnemonic that we use when we are questioning this. PQRSTU. P is what caused it. What brought the symptoms on? What were you doing when you first noticed it? Q is the quality or the quantity. How does it look, feel, sound? How intense, severe? R is the region or radiation. Where is it? If it's pain, where is it? Does it spread? S is severity of the scale. We use a pain scale from 0 to 10 to rate pain. T is timing, the onset. Exactly when did you first notice this? How long did it last? The frequency. Does it occur? And the U is the understand the patient's perception of the problem. What does the patient think? Do they have an idea of what's wrong with them or what's causing the issue? Past medical history. Past medical history, it plays a part into the present illness. So we need to be familiar and ask questions about previous medical diagnoses that could be having an impact on today's illness. Some other things about past health is we need to know about any allergies. If they do have an allergy to something, we want to know the reaction that they have. Any childhood illnesses. This could be, measles, mumps, rubella, chicken pox, rheumatic fever. We need to know about any of these. Accidents or injuries. Any head injuries, concussions, auto accidents, fractures, any chronic illnesses. This could be diabetes, blood pressure problems, heart disease, sickle cell, seizures, cancer, hospitalizations and or operations. We need to know about any operations they've had in the past and when that happened. Obstetric history. This is for our female clients. We need to know about, number of pregnancies, a number of live births that they have had. At what age was did their menstrual cycle begin? If it's an older client, then are they in menopause? We need to know about their last OBGYN Pap test. Immunizations, we need to know if they are up to date on immunizations, flu shot, if it's a healthcare worker, TB skin test, COVID. Older clients, they have the pneumococcal vaccine now, shingles vaccine. We need to know about any current medications, very important. This is prescribed medications, and this is also over-the-counter medications, herbal supplements, any type of medication or holistic medication that they may be taking. Family history. Family history is important because of genetics. So we need to know the age and health, or the age and the cause of death of blood relatives. And when we say blood relatives, we're talking about parents, grandparents, and siblings. We also want to know the age and the health of the spouse and their children. Some diseases that we pay particular attention to is heart disease, high blood pressure, stroke, diabetes, cancers, anemia, alcohol, obesity, mental illness. There's a whole list of them here that we need to pay special attention to, because these are disease processes that can be passed along. Most of you have seen a chart like this if you have gone to any type of urgent care or All South. This is a review of systems. This is just like a checklist that the client will fill out, and it's just a general overall health status. This is subjective symptoms that are perceived by the patient. So if they mark yes to any of these questions, then we're going to follow up with more, open-ended questions to try to dig a little bit deeper into this to find out, when, why, how. These checklists, they break each body system down separately. So you just want to make sure you pay special attention and look over this list and have a general idea of the different systems that we are looking at. And we also want to ask about health promotion practices. Health promotion practices are things that the client does to help them stay healthy. Self-breast exams, males self-testicular exams, mammograms, OBGYN appointments, things that they do to try to stay healthy. Next, we want to talk to them about their daily lives. This is called a functional assessment. So we're looking at activities of daily living. Are they able to care for themselves? Can they bathe themselves, dress, use the bathroom? Are they able to provide meals for themselves? Can they cook for themselves? Or are they dependent on somebody else coming into the home to help them with these things? We're going to ask them about their lifestyle, what their environment is like. Self-esteem, we're going to ask about their, education, the last grade in school that they completing, financial status, are they able to buy their medications, are they able to buy fresh fruits and vegetables. Activity and exercise. Do they use any kind of assisted devices in ambulating? Any prosthetics? What type of exercise they do? How often? How long? Sleep and rest, their sleep patterns. Do they sleep laying flat or do they have to sleep in a recliner? Nutrition. We want to ask them what's a typical meal that they eat. Who prepares their food? Who buys their groceries? Relationships. We want to know about what is their role in their family. Do they have a good support system? Coping mechanisms, coping with stress. How do they cope with this? How do they manage stressful events in their life? Personal habits. This can be talking about alcohol. If so, when was your last drink? We want to know how much they drink, or smoke, or any illicit drugs. What type of drugs they use and how often. Environmental hazards. Do they live alone? Do they feel safe? Do they have transportation to and from doctor's appointments? Violence. intimate partner violence? Do they experience any of this in the home? Do they feel like they have a home? Do they feel like they have a safe home environment? Have they ever been physically or emotionally abused? Occupational health. What do they do for a living? If they're retired, how long have they been retired? What type of work did they do? Because the type of work can contribute to their health. This is an example of a little health questionnaire of how the client perceives their own health. You'll ask the following questions, and they'll rate themselves from 0 to 3. And then you'll total it up, and it just kind of gives you an overview of their overall health status. This slide is going into the health promotion practices. Again, we talked about it a couple of slides back, but again, it's behavior that the client does to increase their well-being, things that they do to help improve or maintain their health. Going to the dentist, routine screenings, blood work, exercising, those self-exams, immunizations.